Recently, I posted one video in which I've put up my opinion about the utility of small incisions, smaller than 2.8 mm. And see, we have a situation here. This is one individual with a cataract and a diabetic retinopathy and was planned for cataract surgery. And this is the point where we are actually seeing the surgery being performed. Capsular access has been done, and being a diabetic patient, these patients may actually have a pupil which cannot respond to dilators. So here we have a limited amount of dilatation, that is something like 5 mm, and then we are proceeding for dissection of the nucleus. And as I prefer, it is usually primary horizontal chop, and after burying the tip for adequate depth, going on for a peripheral chop. So a small pupil has its own limitation, but in any case, if you are able to dissect the nucleus in smaller pieces, that is smaller pies and not quadrants, then this usually doesn't have any detrimental effect owing to the fact that these small pieces will not protrude into the anterior chamber even when you are operating them at a pupillary plane. So the problem with the small pupils is that you don't have very good view, and this forces you to perform the phacoemulsification at the pupillary plane. You cannot go deep because then you know you will be compromising the posterior capsule. So if you dissect the nucleus into smaller pieces, both the purposes are served, that you can still operate in the pupillary plane, keeping intact the PCD, not providing any risk to it, and at the same time, you are able to remain away from the endothelium so as to protect the endothelium from any detrimental effect of the phacoemulsification process. This emulsification process may look very simple and fast, but it actually has been run on at 1.5 times the speed just to speed up the process so as to take us to the point where we are interested to look at. So nuclear disassembly and emulsification has been done, and we can see the anterior chamber and the media has been cleared off. Now this is the point where we are injecting the IOL, and because the incision is very small, smaller than what the cartridge would accommodate, so once I start injecting using the wound assisted delivery, when the IOL emerges, it actually expands the tip. So the tip is pushed back and you have a injector which is pushed out, and the IOL has then not been extruded into the anterior chamber. So increasing the incision size, and because I was suspecting that this is some problem with the cartridge, so I switched to another cartridge which was not from the proprietary or the company recommended. And the problem now is another problem, that the injector is shorter than the cartridge length. So as you can see, I'm trying hard. The injector is just stopping short. So hitting again and again just in an attempt that maybe the optic opens out so that it is released from the cartridge. And then taking a chance, pulling out, and because the optic had opened up, it remained inside. So now this is a situation peculiar to a particular case because of mismatch between the injector and the cartridge. So everything is so much so designed that you have to use the particular model only. So if you have a cartridge recommendation, then you stick to it. Otherwise, you may have a situation. However, the situation was solved, and you can see the IOL has gone into the bag. The pupil is small, something like 3 millimeters at this moment, and the surgery has been done. Now, because this was having some corneal astigmatism, so we have also planned opposite clear corneal incision, and this is executed. And then because the incision is slightly enlarged, there's coaxial irrigation has some leaking beside it, but this should not matter. Flushing any remaining viscoelastic and at the same time inflating the anterior chamber. This is the day one post-op picture, shows a mildly dilated pupil with a clear visual axis. Thank you.